Hello, this is Ms. Hatfield again, and we're going to talk about the therapeutic response. Let's start by talking about some age-specific communication, and we're going to discuss a variety of different age groups and how we all have perceptions and assumptions about various age groups, and we're going to work with various age groups in the hospital setting. So we need to know what is going on in each of these age groups, what's going on in their lives, and how do we communicate with them based on that information. The majority of clients that you're going to see in the hospital are adult clients, and these can be broken into subgroups. We have the young adult age group, which is 18 to 30, and these people are developing intimate relationships with other people. They're committing to work and building a career. And some of the things that we need to keep in mind is that these things are affected by illness and hospitalization. So if you're caring for a young adult, you need to understand and realize they're going to be concerned about those things that they would normally be doing in their life. Those would include developing relationships with other people their age, working on their career. They're going to be concerned about missing work. They're going to be concerned about their significant other, their spouse or their boyfriend or girlfriend. And then we need to just make sure that as healthcare providers, we respect these concerns. If they're concerned about work, ask, is there something that we can do? Can we get you a slip or a note for work? Something that might help you in that respect. And then the next age group is the adult age group, which is 30 to 65. And these people in general are focusing on family and guiding the next generation. We need to know that these people gain satisfaction from their personal and professional achievement, and this is going to be their main focus for their life. So if you stop and think for a moment about what is important to this age group, it's going to be things like being pulled away from their family. They may be the breadwinner in their age group. They may be caring for young children, and they're going to be concerned about being removed from these very important roles while they're in the hospital or while they're sick and trying to recover. Once again, you want to treat this person with respect, listen to any concerns that they have, and try to help them, problem solve in any way that you can. If there's something you could do to help them make contact with people outside of the hospital to help take care of these responsibilities that they have while they're in the hospital, then that can be very helpful to them. The last age group that we're going to talk about is the older adult, and that's going to include the 65-year-olds to death. And I also want to just point out that these ages are kind of used as general ranges. Certainly people in other age groups can be focused on things in an age group that I'm not necessarily placing them in, but still that's what's going to be important to them. With the older adults, we want to hopefully see these people have a sense of satisfaction with their life. We want to help them hopefully become accepting of their life. They're also going to be thinking about death to some extent. Some of the things that we can do as healthcare providers to help these folks is to use them, treat them with respect. Don't use names like honey or sweetheart or grandma. Don't use their first name without permission. Make sure that you're treating this person with respect and call them by the name they want to be called by. And then sometimes they still have the same level of intelligence as everyone else, but sometimes it takes them a little longer to process information. So you may want to allow them more time to respond to questions, and just slow down your conversation. Don't be in such a hurry. Remember that this is part of communicating with them and treating them with respect. And lastly, avoid stereotyping the older adults. Everyone who's 65 or older is not forgetful. They're not all confused, and they're not all hard of hearing. So, you don't have to yell at them. You don't have to assume that they're disoriented or don't know who they are. You need to treat them with respect. As a healthcare provider, you should know that being sick can be stressful. Taking care of sick people can be stressful as well. You may be asking exactly what is stress? Well, stress is defined as mental or physical tension. So pretty much anything can result in physical or mental tension. So therefore, it could cause you stress. Some examples of stressors might include traffic, money issues, having a sick child at home, having a lot of stress at work, dealing with death and dying, studying for a test at school or taking a test would certainly be a stressor. And then there are some things that are stressors even though they're considered good things in your life. And that an example of that might be getting married. You still have a lot to deal with and to prepare for, but it's considered a good life event. Stressors can affect how we deal with our day-to-day living, but one thing you need to understand is having stress does not mean we have an emotional disorder. We all have stress. So, keep that in mind. We all have stress, and that does not mean we have an emotional illness. Stressors can be defined as internal or external. An internal stressor might be something that comes from within you. Let's say it's really important to you to get all A's. You want to get 100% on every assignment that you do. So you really stress yourself if you score anything below that. That would be considered an internal stressor. An external stressor might be anything that comes from an external source or from the environment. An example might be your car breaks down on the way to work. That would certainly be an external stressor and something to deal with. There can be physical, emotional, and environmental stressors that affect your patients as well in the healthcare setting. Certainly, just being sick is a physical stressor. And when your patient is sick, their body goes through a variety of responses to try to help them deal with stress. But just being pulled away from their lives and their responsibilities and their roles at home can be an emotional stressor as well. And then sometimes there are environmental stressors that affect our patients in the hospital that we don't even think about. Let's say we moved a patient from a private to a semi-private room. Well, suddenly they're sharing a room with someone else, and they're worried about, that other person hearing them or being somehow overhearing something or seeing something that's private, and that can be considered an environmental stressor. So these are certainly all things to take into consideration with your patients. We also need to be aware of patients' behaviors that could indicate stress. Stressed behavior is anything that varies from a person's normal behavior. And when we have patients who are sick and in the hospital and under a great deal of stress, sometimes they can demonstrate behaviors that seem abnormal for them in any other time in their lives. We might have a patient who yells and swears at staff members because they just don't feel like they're receiving good care. This may not be something that person would normally do in their life outside of the hospital setting and outside of the sick role. But being in that position has stressed them to the point that is one of their stress behaviors. That's an obvious stress behavior. A less obvious stress behavior might be something as simple as pacing the hall quietly. Patient may not let you know verbally anything about their stress, but they may just pace back and forth. They may be fidgety or unable to sleep, and all of this can be due to stressors. So there are a variety of different coping mechanisms or skills that we use to try to deal with stress. During times of stress, we all tend to use familiar coping mechanisms or things that have worked for us in the past. One thing to keep in mind is that coping mechanisms may be healthy or unhealthy. Later on, we're going to talk about defense mechanisms as well. And the difference in a coping mechanism and a defense mechanism is that coping mechanisms are voluntary. These are things that we choose to do to deal with stress, while defense mechanisms are not voluntary. They're behavioral changes that we have that help us to deal with stress, but they're not voluntarily chosen to be done by us. So let's start off talking about healthy coping mechanisms. Well, a patient or any one of us really may choose to deal with stress by exercise. Maybe there's a particular type of exercise that you like, whether it's golf or soccer or heading to the gym. Some people may actually pray or meditate to help deal with stress. And then we have unhealthy coping mechanisms such as drug use, smoking, overeating, drinking, Any of these things can be used to deal with stress, but they certainly are unhealthy for our bodies in a lot of ways. So each person kind of makes that choice about what helps them or what they think helps them to deal with stress. And obviously some of these coping mechanisms can cause more stress in the long run, especially if they're unhealthy. Let's talk about defense mechanisms. Remember, we said defense mechanisms are ways that we deal with stress that are involuntary. We're going to talk about regression, repression, denial, and rationalization. And it's very important that you kind of have an understanding of what each one of these terms means. And believe it or not, we all have probably used at least one of these in our personal lives at some point to help us deal with stress and anxiety. So defense mechanisms can offer a way of dealing with stress, but we are totally unaware. These are involuntary. These are ways that we deal with stress that we don't do on purpose. The first one we're going to talk about is regression. If someone regresses from their normal state of behavior, this is one way of dealing with stress. And with regression, a person will move back or retreat back to behavior that worked for them in an earlier time in their life. Probably one of the most common examples of this would be a toddler or a 3-year-old who has completely weaned off of using a bottle, and then they get a new sibling, so this adds new stress and anxiety into their life. So they regress back to using a baby bottle or wanting to use a baby bottle, and that's just their way of coping with the stressors of having that new baby come into the family. The next type of defense mechanism I'm going to talk about is repression. And if we repress something, we are unconsciously choosing to forget the experience or the information. And this is kind of a form of temporary amnesia, and it just helps our minds to protect ourselves from being overwhelmed with circumstances. And a common example of this might be a rape victim who is taken to the emergency room, and while they're being examined, they just say that they don't remember what happened to them because it's just so stressful for them that their mind chooses to repress that memory because it's too much for them to deal with right now. Another common defense mechanism is denial. Denial is pretty common in people dealing with stressful situations, and it's an unconscious refusal to acknowledge a painful reality. An example might be an alcoholic who says, I only have a little drinking problem. I really don't drink that much, and it doesn't really affect my life. When in reality, their life might be greatly affected and damaged by their alcoholism. And then lastly, I want to talk about rationalization. And this is just another defense mechanism that includes justifying your behavior by giving an explanation rather than a truthful response. Rationalization usually has a grain of truth to it, and it's typically something that we find to be an acceptable reason or excuse for your behavior. An example might be that someone is late for work, therefore this person did not get a raise, and then he blames it on the boss, saying that the boss just doesn't like him, and that's why he didn't get a raise. So that would be an example of rationalization. Okay, we're going to start talking about some of the behavior that you may see in your clients or patients in the healthcare setting. And there are 3 different types of patients we're going to talk about, and you might say that these patients are distressed. Certainly it can be distressing to be in the hospital, but then sometimes you can see stressed behavior on top of that lets you know that your patient is in distress. The first distressed client we're going to talk about is the angry or aggressive client. And when I start to talk about this type of behavior, students sometimes get a little anxious and nervous that, they're going to meet a lot of patients like this in the hospital. But what I try to tell them is, no, you're not going to meet a lot of patients like this in the hospital. But what you're going to find is when you do meet one patient or any patient like this in the hospital, it is very important to know how to respond. and it quickly becomes a situation that you want to know how to respond to. So let's talk about this a little bit. Patients often become angry because they're frustrated or they find a situation to be offensive, and they might be using this anger as a coping mechanism because they feel powerless. Being hospitalized when you're used to being an adult who is independent and taking care of yourself, and now you suddenly have someone telling you when to eat, where to eat, how to eat, when not to eat, when to get up, when to sleep, when not to sleep. And then sometimes, they've been given bad news, or they have lost all their control of what's going on in their lives. And they may be responding to you with anger and aggression when it's not personal toward you at all. But it's certainly something that we want to respond to quickly. The angry or aggressive client or patient may be demanding. They may complain a lot about their care and about the staff. You may see people who are threatening. They're going to be critical, rude, sarcastic. They won't cooperate with what you need for them to do in order to take care of them. Some people may even become suspicious of the staff. And they may antagonize or try to cause problems with the staff members. First rule is, remember, don't respond to this person with anger. The more calm and cool you stay and remain, the more you're going to help that person to calm down. When you respond to them with anger, it typically continues to make the situation worse. The second rule is going to be listen. Listen to what they're telling you. Look at their verbal and nonverbal communications. Don't rush the interaction. A lot of staff members or healthcare providers may try to get away from the angry client as quickly as possible. They realize that a patient's angry and they get out of that situation as quickly as they can. Well, keep in mind that does not help the situation, and it often makes it worse, because then that person feels like they can't have their needs or their concerns heard by the staff. And then the next very important rule that you need to remember is don't personalize inappropriate comments or remarks from the patient or the client or their family. It's not about you. They may call you a name. They may say something rude to you, but it's not about you. It's really about what's going on with that person. You may walk into the room and they start to yell and scream at you and tell you how bad the chicken salad is, and you people can't get anything right, and I keep getting these chicken salad sandwiches, and that's not what I ordered, and they're screaming and they're crying and yelling. But really, is it about the chicken salad? No, it's really not. It's probably about this person's feeling of powerlessness, lack of control. There may also be physical clinical causes. They may have some type of disorder or disease going on in their body that's causing them to act this way. So it's not always under their control. Try to listen to your patient. Hear them. Hear what they're telling you. Don't blow them off. Don't give them reassuring cliches or say things like, I'm sure everything's going to be okay. It'll be fine. You'll get the sandwich that you ordered tomorrow, that kind of thing. You want to try to do what you can to help this person solve whatever issue it is that they have. If you feel like this person is going to become aggressive toward you, of course you want to call a code silver. You want to contact the nurse who is in charge, or the nurse in charge of this patient, and then make sure that you can try to get this person's needs met as quickly as possible. You might say something like, we didn't get you the sandwich that you ordered. Well, let me order you another sandwich, and while we're waiting for that one to come up, let me help you sit down and fill out your menu for tomorrow, so that we can make sure we get your menu turned in as quickly as possible, so that hopefully you can get the right sandwich the next time. Don't ever promise to fix a problem for a patient. All you can do is promise to offer them any help that you can provide. You can't promise them that whatever the situation is, it'll go away, but you can offer them solutions and assistance. And that's all you can do in that moment in time. Just to kind of reiterate what I said, speaking calmly, listening to the client, attempt to solve the problem for the client or the patient, and don't walk away. If you try to avoid the problem, typically it's going to get worse. So keep in mind, we are there to help these people, and helping the angry or aggressive client is part of this. All right, the next distressed client that we're going to talk about is the anxious client. And anxious clients are people who are experiencing a subjective emotional response to stress or a stressor. Anxiety is a feeling of fear, worry, uneasiness, or dread. And there are 4 levels of anxiety: mild, moderate, severe, and panic. And it is very important that you are familiar with all 4 levels of anxiety and that you are able to identify behaviors that go along with each of these 4 levels. Some of the physiological changes of anxiety in general are going to be that the pupils become dilated, your heart rate and your rate of breathing is going to increase. You might experience a sense of dry mouth, and the skin can become cool and clammy. You might hear people say their palms are sweaty as well. These are all normal changes that relate to anxiety. Let's start talking about those 4 levels that I mentioned, though. Let's start with mild anxiety. When someone has mild anxiety, this is usually in response to tension that happens in their day-to-day activities. And it typically just stimulates a person to act. It prompts you to move or to make an action. There's an increase in perception and awareness, and they become more motivated. Typically, people's performance increases. You may be in clinicals and you see your instructor coming down the hall and you think, oh, I better not be just sitting here on this chair. I better get up and go check on my patients and, do something to make my instructor think I'm busy. Well, that mild anxiety caused you to get up and do something. It caused a change in your behavior. But it wasn't so severe that it caused you great distress. If you come across a patient who's having mild anxiety, some of the things that you can do to help this person is to give them information. Give them instructions about what you're going to do and how it's going to happen. You can give this person detailed instructions. You can say, let's say they're going to go for a test and they're really anxious or nervous about it. You can actually say, okay, so in a couple of hours, the transporter is going to come and get you. We're going to help you get changed into a gown. Then we're going to make sure that you've got all your personal belongings together. Then we're going to put you on the stretcher and they're going to wheel you downstairs, and they're going to take you into a room that might feel a little bit cold. And you can give them, a great deal of detail before a test and procedure, and that will actually help this person. Then let's talk about the person with moderate anxiety. Now we are going to see physical and behavioral changes that can be noted in their vital signs. Their heart rate and their respirations will actually increase, and we don't see that always with mild anxiety. They're going to become sweaty and tense. They're going to become irritable and just a little more testy in their behavior. And they might tell you that they feel like they have butterflies in their stomach. So they're just going to tell you, I feel like I have butterflies, or my stomach's just all tied up in knots. So they're starting to have physical changes and manifestations of this anxiety when it gets to the point of moderate anxiety. The client is still able to understand what you're saying, but they're unable to always understand the overall situation. So what you can do is help this person is to focus on a particular task or detail. So rather than tell the person, all the different details about what they're getting ready to go through, focus on one detail at a time. Speak in a soft, calm manner. And anytime something changes, keep them well informed. Let's say their test gets postponed for 2 hours. Well, then you might make sure you tell them as soon as possible. That's going to help them because it helps them have a sense of being informed. If your patient was pacing, this would be a physical behavior that manifests anxiety. If they're pacing really quickly, one of the things that you could do to help this person is to walk with them and gradually slow your pace. And what you may find is that they actually slow their pace as well. And to the point that you can get them to a stop. And then you can redirect this person and say, okay, let's go over here now and let's sit down on your bed and get them to think about something else. Severe anxiety. With severe anxiety, the person becomes unable to concentrate. They have alterations in their perceptions, or in other words, they don't fully understand everything that's going on. They cannot no longer understand abstract instructions or details, and there are going to be some more obvious behavioral changes now. They're going to be profusely sweating. They may be shaking, visibly shaking or shivering. They're going to have an increase in their heart rate and their breathing. They may have purposeless movements and just kind of flailing about in the bed. They may even become confused. Some folks will even experience uncontrolled crying. At this point, if you have instructions or information to give, it may be best to give it to a family member who is there with this person who can share it with them later. You may also put the instructions down in writing so that if it's something the patient needs to know, they can refer back to it later. And then just give them very specific instructions on what to do and do as much for them as possible, because they're not going to be able to take care of themselves at this point. The next step above that is going to be panic. With panic attacks, or the panic level of anxiety, the anxiety becomes so intense that this person will have physical symptoms that are very distressing to them, and they can be very distressing to the healthcare team as well. They become short of breath. They may be physically trembling or shaking. They're still going to have that increase in their heart rate and respirations, but now they may tell you they're experiencing chest pain, dizziness, hot flashes. They will also tell you they feel like they're going to die, that something really, really bad is going to happen. The best thing you can do for this person is to stay with them, don't leave them, and tell them to focus on you. You need to let this person repeatedly know, I'm going to keep you safe. I'm going to keep you safe. Just focus on me. Someone's going to stay here with you at all times. Just look at me and try to breathe. Because at this point, the person's anxiety level is so high that they need instructions like that. Typically, the onset of these symptoms is very sudden, and this can be very scary for a patient, and it can last up to half an hour in some patients. So just make sure you don't leave them, stay with them, tell them to take slow, deep breaths and to focus on you. Let's talk about the depressed client. The depressed client is the next type of distressed client that we're going to talk about, and we all have times and periods in our lives when we feel down. But depression is characterized by an overwhelming feeling of worthlessness, hopelessness, or guilt. This person's physical appearance may go downhill, they don't enjoy things as much as they used to, and they may have thoughts of suicide. Sometimes big losses in someone's life can look like depression, but they're normal responses to loss. And an example of that would be the death of a family member, having a life-threatening illness, loss of a body part. Some of these things can cause severe grief responses that seem like depression. So how would you know if someone was depressed? Well, look around their room. Is it dark and quiet? Are they just laying in the bed and they won't make eye contact? They don't get cleaned up. They don't seem to care about themselves or their environment. They may look disheveled. Sometimes the best thing that we can do for these people is just simply to be there with them. Cheering them up is not the answer. Saying, oh, I'm just going to go in and make Mr. Jones smile today, is not going to fix their depression. Remember that a person who's experiencing depression doesn't need for us to go in and just cheer them up. Sometimes just being there for the person, spend time with them, let them know that you're there to listen to their concerns, and allow them to tell you about their feelings. That's really the most important thing that we can do for these folks. And then another important piece of taking care of a depressed client, and Centera has really talked a lot about this in recent years, and that's identifying someone who is at risk for suicide. If a patient says anything to you that makes you think they're feeling like they might want to hurt themselves or end their life, then you need to let the nurse know that as soon as possible, and we need to take every one of these concerns seriously. If a patient says something to you like, "I'd like to go to sleep and never wake up," that might be a red flag that they're thinking about suicide. You want to tell the nurse that. If the patient says something to you like, "My family would be better off if I just wasn't here or if I wasn't alive anymore," that would be something to tell the nurse. Don't minimize or ignore this type of comment. This person may be even unconsciously thinking about suicide, and they need to have a healthcare provider come in and explore this with them. The most critical aspect of dealing with someone with depression is the potential for suicide. And even though most care partners don't go to work in a psych unit, there are patients with mental and emotional disorders all over the hospital. So there's always a possibility you're going to come across someone in the healthcare setting who's experiencing depression and may be at risk for suicide. Always take their concerns seriously. Always listen to them and share your concerns with the nurse and the rest of the healthcare team. The last type of distressed client that we're going to talk about is the chemically dependent client, and this just refers to patients who are abusing substances of some type. And the most important thing that you need to keep in mind about these individuals is that they may be going through withdrawals physically of some kind. Depending on the type of substance that they're using, it's going to depend on the type of withdrawal that they go through. So you're just going to want to talk to your nurse about the different things that you may want to watch for, whether it's becoming confused and disoriented, or it may be something like changes in their vital signs. That could become an unsafe situation for that patient or life-threatening, and you'd want to report any changes to your nurse. As far as their behavior goes, these people may use denial to avoid dealing with their problems. They might blame others or try to rationalize their behavior. And then some of them may just be flat out honest with you. We had a patient recently in the hospital setting who just told us she couldn't wait to go home to smoke a joint and get drunk. And that was what she was looking forward to, and she was very honest and flat about it. But some people may not. They may try to hide or cover up the actual amount of substances that they're using. And it's just important for us as healthcare providers to remember we're not there to judge these people. We're not there to tell them, that they're bad people or they're doing things that are wrong or immoral. We just need to hear their concerns, be aware of what they're going through or some of the withdrawal symptoms that they may be having, and then just be available for them if they need to talk. That concludes this particular PowerPoint presentation. And just to kind of review and wrap things up, you need to remember there are different things with different age groups that you need to keep in mind when you're caring for people of different ages. There are different types of stress, and there are different ways of coping with stress. There are also a variety of defense mechanisms that we need to keep in the back of our mind and be aware of. And then there are different ways that patients respond to stress that may make them a distressed client or a distressed patient. And there are certain things that we can do to help these people and to not hinder them or make them more stressed. So that concludes our PowerPoint, and if you have any questions, please contact one of your instructors.